That is surgical tips and tricks for complicated pediatric cataract. I think each procedure we do, whether any procedure you do, you pray to God. But we remember our Guru also. So I owe my gratitude to my mentor and teacher. They are my mentor and teacher. Before me, I became head of the department after Professor Amod Gupta. I also owe my gratitude to mentor in pediatric cataract surgery. While I worked with Dr. David Apple, I got opportunity to work with Dr. M.E. Wilson, who was pediatric surgeon, and I also achieved my inspiration for pediatric cataract from Dr. Abhay Vasavada. While we see these children with pediatric cataract, usually they come with visually significant cataract, and I think I have documentation of more than 12,000 children, their clinical photograph as well as wherever possible slit lamp photograph also. Each of the child which you operate, it is better to dilate the pupil, because dilatation will tell you that what is the type of cataract, whether it is a zonular cataract or whether it is a posterior lenticonus or it is a PHPV or persistent fetal vessel or any other problem of dilatation. So I think first is just a small simple video. In a more complex pediatric cataract, we have to diagnose, then plan what type of surgery, innovate, sometime execute, and I think extremely important is follow-up of these children. First, I think already Dr. Parul Chawla Gupta as well as Dr. Jaspreet, they have already highlighted the steps of pediatric cataract surgery in a normal case. But this is a very small video clip that how you make main incision, side port incision, and stain the anterior lens capsule and perform continuous curvilinear capsular axis. Ideal size is approximately 5 mm or so. After hydrodissection, remove the cortex from the capsular bag. Remove each fiber of the cortex and then do primary posterior capsulotomy. Initial nick is with needle cystitome and followed by formation of the posterior axis by Utrata forceps. Usually there will be least vitreous disturbance, but any little vitreous traction, I think you remove that. And place IOL, as Dr. Jaspreet said, in the capsular bag. It is always hydrophobic acrylic IOL, but we have used initially PMMA IOL or heparin surface coated IOL also. Then going to the complicated pediatric cataract cases, several cases you see PHPV, posterior lenticonus, ophthalmos, microphthalmos, JIA cases. So here it is a first case which is a 2-year-old child with pre-existing posterior capsular dehiscence. You can see the anterior segment OCT on the side. We anticipate that this child will have posterior capsular tear. So you have to do limited hydrodissection and remove the cortex from the capsular bag. So as anticipated, there was a posterior capsular tear, and IOL is implanted into capsular bag. And sometimes little traction may be there, vitreous traction, so that is removed. Best is detected by triamcinolone injection, and this is 8 months later, clear visual axis, and this is IOL position by anterior segment OCT. This is another child with juvenile idiopathic arthritis with uveitis. Synechotomy was done, and Malaysian ring is injected to achieve good dilatation of the pupil. And now we achieved excellent dilatation, excellent size pupil, and then of course removal of the cortex and doing cataract surgery not difficult. This clip is, I think, more than 15-year-old. That time we only had this Malaysian ring. Now we have Bhattacharya ring and several other rings also. So here we did peripheral iodectomy because we expected that there will be occlusio pupilli. Then come another case with lenticular coloboma with high corneal astigmatism. So here it is not issue of implantation of the IOL. Here there is another issue that we have to achieve centration of the IOL. I think which is best achieved by fixation of the capsular bag. These are the capsular hook. And cortex is removed from the capsular bag. And Sioni ring is implanted into capsular bag, and to achieve the perfect centration of the IOL in the bag. So here we are using toric IOL, using Callisto, and this is after implantation of IOL in the bag, and then now we achieved excellent centration. This is to show the before surgery and after surgery implantation of the IOL. And then comes a double crystalline lens. I did this a very small clip having two lenticular two lenses in the same eye. Here I think this is the only case where I did two continuous curvilinear capsular axes on each of the lobe of the lens, and we designed a customized IOL. And this was a 18mm long IOL which was implanted into each of the capsular bag. Central area was aphakic. So amblyopia therapy was initiated for this child. And this child could achieve good vision. We have follow-up of more than 10 years for this child. Child is myopic by 1.5 diopter. Then probably the last clip where it is a 1-year-old child with PHPV. It is a hemorrhagic type of PHPV. So these are this is again a complicated situation where we have to do cauterization of the uh, vascularized posterior capsule and primary posterior capsulotomy. Usually vena seizure may help you because sometimes even cutter will not cut a thick membrane. Here it is just cutting of the stalk after cauterization and doing limited anterior vitrectomy. And here we can do optic capture again, optic in the capsular bag and haptic in the sulcus. So these are some of the other cases of PHPV. Classical PHPV, this is a very advanced PHPV where posterior capsule is totally vascularized. So this is where it is extremely important to achieve long-term follow-up. One child where IOL was implanted in 1997 and after 25 years in 2022 he completed his MBBS. It means his vision was excellent. His vision is 6/6 but he is myopic. Of course myopia is good for him. It is 1.5, 1.75 diopter myopia. So I think that is not a very big thing. But I have a follow-up of 33-year, 35-year, up to 40-year follow-up of these children. And anyway, I am thankful to all of you for attending this